Pop Health Podcast is a public service of 24-hour home care. Hello, everyone, and welcome to another episode of Pop Health Podcast. This is Gavin Ward, host of Pop Health Podcast. In today's episode, I sat down with Karen Johnson, the Medicare officer for HealthNet, one of the largest health insurers here in California, and also part of the Centene Corporation, a Fortune 200 company serving much of the United States. In today's episode, we learn of Karen's journey from candy striper to nursing school, then to law school, and ultimately how she's a mother of 5, has moved 16 times, and now leads a HealthNet here in California. We also learn of HealthNet's efforts leading into 2021, including some changes and some great additions to their health plan, and also what HealthNet is doing to address healthcare disparity here in California and how Centene is working on that throughout the United States. We hope you enjoyed today's episode, and feel free to find other episodes of Pop Health Podcast by visiting pophealthpodcast.com, finding our YouTube channel, or of course listening to us on Apple Music, Spotify, or Stitcher as well. Thanks everyone. Enjoy the show. Karen, share with us something about you that might surprise the audience, something outside of the workplace.
As I think about it, Gavin, I've lived in 4 states and moved about 16 times.
Woo.
And we have 5 children.
Those are some good numbers there. So really quickly, the 16 moves, was there any inspiration behind that?
Yes, actually, a few things. So, most of those moves were a result of being relocated for work. And with that, it required, the initial move, which put you in corporate housing. Then there was, renting a place for a bit of time while you determine, where you wanted to ultimately land and live, and then finally purchasing something. So within all of that, it necessitated quite a few moves.
Oh, yeah. And I know your last move, we talked off the air, was from D.C. to here to work alongside someone that you've known in D.C. But there was something that helped you say yes to that. What was that?
Yeah, that was my youngest daughter. She, when she graduated from college, she decided that she would come to California and relocate, and she'd never been here. And so it was a little unnerving to have her go, on the other side of the country. And so when the opportunity presented itself for me to relocate and take a new job here, we decided that it was a good move for us. Moved here about 6 years ago and haven't regretted it.
Awesome, Karen. So at what point in life did you decide to jump into healthcare?
As long as I can remember, I had an interest in healthcare, but what probably sticks out the most was when I was a candy striper. That was early high school, probably late junior high. And it was, you dressed up as a volunteer in a uniform that had stripes on it. And I volunteered at the local VA, the Veterans Administration Hospital that was near me. And so I was hooked on healthcare from there.
Nice. So your background, you became a nurse, and then you decided to jump into law school. Tell us briefly about that.
Yeah. So when I was in my nursing program, it was a 4-year program, and my nursing school was really focused on preparing nurses for administrative work versus kind of clinical bedside. And what I found probably around my junior year or so is that I realized that there would be opportunities for me to do things where I could have a greater impact in the healthcare space. Really, I saw things that made me know that I wanted to be able to have a greater voice. And so, I had some family members who were attorneys. I had, some adults that I respected and talked to them a bit about advocacy. And they said, there's nothing that would stop you from going to law school. You don't have to have, an undergraduate degree in any particular area. You just need to perform well on that LSAT test. And so I had a really good advisor in college who also kind of supported that and reminded me that, it was important for me to finish my nursing program because there would always be a need for nurses.
Yes.
And so I did that. And so initially, I started my practice as a nurse, but then I very soon thereafter got myself into law.
Okay, nice. So today you're the Medicare officer for HealthNet, which is part of Centene. And some of our audience may know what Centene is, since it's such a large organization, but candidly, I've been in healthcare for almost 20 years and I'd heard the name Centene, but I didn't know exactly what it was. So before we jump into HealthNet, can you talk about briefly the parents, Centene?
Yes, so Centene, it's based in St. Louis, and it's a very large, a Fortune 200 company with about $75 billion in revenue. And it is really a multi-lined enterprise that primarily works in the government-sponsored space. We focus on the underinsured or the uninsured. We do also provide health insurance for the commercial space too, employer-sponsored plans. But really our sweet spot is government-sponsored programs. We also have some specialty companies like dental, vision, et cetera, pharmacy. But really at the heart of it, we're a multi-line managed care enterprise. And so it's our parent company for the local plan here, HealthNet.
Okay, great. And then can you briefly share, again, I think most of our audience probably knows who HealthNet is, but share about HealthNet and then share about your particular role as a Medicare officer.
So here in HealthNet, we've been in the market for a number of years, and we offer a variety of healthcare products and lines of business, and really geared towards being able to serve residents of California, no matter where they are on the spectrum, from newborns to seniors. And so we offer a variety of different programs, one of which is we provide programs that are in the Medicare space. And so I am the Medicare officer here for California, and my primary responsibility is to drive the strategy for our Medicare line of business, of which we have several products that fall under Medicare. So I have responsibility for strategy, for ensuring that we execute on that strategy, for driving new products, ensuring that our network is accessible, that we meet, clinical quality requirements, and that we meet our contractual requirements that we have with the federal government, which is the Centers for Medicare and Medicaid.
Okay, great. Thanks, Karen. Now, for HealthNet and your Medicare side of business, I believe you said a little less than 200,000 members. And part of what makes HealthNet different than Medicare is the ability with your Medicare Advantage plan, for example, to offer supplemental benefits, which is different than supplemental insurance. Can you briefly share with the audience the difference between the two, and then maybe some examples of supplemental benefits?
Right. So in traditional Medicare, people have coverages, and you hear it referred to as, Part A and Part B. And so what that means is that once you're eligible for Medicare, you can have access to coverage that provides physician coverage, physician visit coverage, as well as hospitalization. You can also, buy, in addition, coverage that will take care of your medications if you need medications. That's in the traditional world. So in the traditional Medicare, you have that Part A and Part B, and then if you like, you can also buy for a cost your additional pharmacy coverage. But there are gaps. There are things that are not covered in that traditional Medicare, and so for that, there are supplemental plans that you can purchase. And that supplemental plan can, cover things like additional co-payments or co-insurances that you might have in your plan. It may cover your costs for your pharmacy co-payments, et cetera. That's what a supplemental plan is. You'll hear it referred to as a gap, a Medigap program. In a Medicare Advantage plan, it's different. In a Medicare Advantage plan, what happens is the health plan actually contracts directly with CMS. And by contracting with CMS, then what we do is we basically take over the administration of the Medicare benefits for those people who choose to join our plan. And so what they get is they get their physician services as well as their hospital services covered. And they also get their Part D, which is their pharmacy coverage. And so you'll hear Medicare Advantage plans referred to as Part C plans. And that's because they're covering all three. They're covering physician, hospital, as well as medication. And then the real beauty of a Medicare Advantage plan is that we have to, at minimum, provide the same benefits that one would get in their traditional Medicare, but we also have the ability to offer additional supplemental benefits over and above that. And those supplemental benefits are things that people really find attractive. And so there will be things like vision and eyeglasses, for example, are covered as a supplemental benefit. We provide dental coverage, dental benefits, which are not things that you get in your traditional Medicare. We provide things like transportation to your medical visits. We provide things like over-the-counter benefits, so people can go into, their local drugstore and get things like Tylenol or buy a blood pressure cuff if they need one, because they have a certain amount of dollars that they can spend in over-the-counter items. So those are the types of additional supplemental benefits that we offer.
Okay, nice. Now, I know one of the supplemental benefits can be for fitness, and we're recording during the pandemic where maybe access to gyms and things like that aren't available. Can you give us an example of how folks have utilized their fitness benefit, or maybe some of the changes to the fitness benefit this year?
Yes. So, historically, what we offered were, your traditional people could select a gym to go to. We actually have a pretty few unique options where people can also, if they choose, they can access fitness credits, and they can use them differently than just going to a traditional gym. But when the pandemic set in, we had to really quickly pivot and figure out how we could still make available to our membership those who wanted to take advantage of fitness benefits. And so we were able to partner with our vendor partners, and we were able to offer fit kits that we could send to people's homes. We mailed them to them. And within their fit kit, there were things that they could use to, stay in shape at home. We were able to offer Zoom and webinar type fitness classes that they could take online. So they had the fit kit at home, which had things like bands, etc., bands, and they could then, tune into a class and be guided for how to use them, and they could, do fitness that way. So we really tried to make it so that people could still take advantage of fitness if they wanted to, even though they were being asked to shelter in place and not be able to go to their traditional, fitness gym.
So we just talked about the fitness benefit and how that's changed during the pandemic. What else has changed at HealthNet, and how have you guys responded over the last 6 months?
So we've been able to do a few things that we're really proud of, and that we think really helped our communities. One is that CMS made the decision that allowed us to do two things. One is we were able to offer telemedicine benefits to our beneficiaries who had elected to join our plans. And so what that meant was we had to ensure that our providers had access to, telemedicine options, as well as where possible to make sure that our membership knew that that was something that they could do. And so we were able to offer about $13 million or so in grants in the various communities to providers, so that they could have the type of equipment that they needed to be able to engage with their patients and to do things so that they could see them, via telemedicine. We did and provided training for providers, in terms of how to document, because it's very important that they have appropriate documentation when they do these types of visits, so that they can bill appropriately and that we in turn can get reimbursement from the federal government for those visits. So we did a lot of training with providers, and they really appreciated that. We also then did outreach to our members. We did telephone calls to members, particularly those who we had identified as being high risk. Yeah. So we had our case managers and teams reach out to those folks to let them know, to check on them, first of all, to make sure that they were okay and if there was anything we could do to assist them. But also we wanted to make them aware that they could get their visits through telemedicine, whether it be FaceTime or whatever mode they could do so. And that was really well received by our membership.
Nice.
And then finally, what I would share that we did was we made the decision that we wanted to ensure that our members who needed it could get meals. And so we marshaled throughout the company nationally to provide and to send meals to our members who had been identified as high risk. We were able to stratify them and then to get meals sent out to them, and these meals were also customized based on what their health needs might be. So, for example, if someone was a diabetic, then our vendor was able to send them meals that would be appropriate for a diabetic, for example. And then, finally, what we've continued to do is to kind of check back in with members to ensure that, they're doing okay, because we think it's very important to keep a pulse on our members, in this very difficult time.
That's great. That's a great response. I know you didn't get into it too much, but I also know your internal team shifted very quickly and pivoted to be able to successfully work from home, which then gave you the ability to focus quickly on your members, which is great. So we're recording here, getting towards the end of 2020, looking at 2021. What can you share is going to be new in 2021?
So, we've just really ready to launch now our new benefits for 2021. And so a couple of the things that we've been able to do is we've been able to enhance some of our benefits, and by enhance it, I mean, for example, in some cases where we had a premium, we now have been able to reduce it to zero premium for the plan. We've been able to reduce some co-payments for things for people so that they have less out-of-pocket cost when they select our plans. And then we've also been able to add some supplemental type benefits. So we've been able to enhance things like our acupuncture and chiropractic services, for example, which is really important here in California because we serve such a diverse group of Medicare beneficiaries. So having those types of options, really people appreciate that and are able to take advantage of it. And then the last thing I would say that we are doing new for 2021 is we've really been able to enhance our pharmacy benefit. And so for those medications that people take, particularly for chronic illnesses, things like high blood pressure or diabetes, et cetera, we've been able to put those medications that they utilize into a tier where there's very little out-of-pocket cost for people. So we don't want them to have barriers that prevent them from being able to get their medications, because oftentimes seniors are on fixed incomes. And so it's really important that there's nothing that gets in the way of their ability to be able to get their medication.
That's great. Supplemental benefits are definitely something my mom takes advantage of. She's a Medicare Advantage member, and she loves her gym membership. I know you as well. So it's great that you have the fit kits so people can still be encouraged to continue.
That's right.
So Karen, we've been doing the show for almost 5 years now. We've done the health plan mini-series. This is our third year. And delegation happens a lot behind the scenes. And some of our audience, who are mostly healthcare professionals, know what that means. But can you explain what delegation means between a health plan and a medical provider? And I'll leave it open-ended for you.
Okay. Yes. So here in California, we're a little unique in that we have a delivery system that really works primarily with large groups of physicians, often referred to as independent practice associations, IPAs, which are comprised of primary care physicians, as well as they build a specialty network as well, so that people who have selected these providers have access to their specialty care. They will work with, certain hospitals, et cetera. And because of that model, what our health plans do is we actually contract with those entities. We contract with those IPAs. They typically have a management service organization that they work with who kind of provides for them their back office, so they provide services for them like claims payment, billing, the administrative staff that supports the office, et cetera. And so what we do as health plans is we contract with those IPAs. And by virtue of doing that, we delegate to them many activities. And so we can delegate things to them, such as credentialing, to ensure that the providers who are going to see our members have the appropriate credentials, that they're licensed appropriately to see patients.
Okay.
We delegate to them the ability to process claims, for example. We delegate to them the ability to do some types of utilization management. So to do things like pre-authorizations, to process referrals, to initiate referrals, those types of functions, as a health plan, we can delegate. So we kind of assign the authority to those organizations to perform those specific activities. But what that doesn't mean is that we delegate the accountability. So we are ultimately still accountable for the outcomes that are a result. And the way that we do so is we do have very specific oversight of those delegated functions. We meet with those groups regularly. We review and audit what they're doing to ensure that they are complying with the requirements that we have agreed to in terms of our delegating to them.
Great. Thank you so much. You can explain it way better than I can, so I appreciate you doing that. So lastly, Karen, as we wrap up the show, one thing that I know about you is that you're involved in addressing healthcare disparities. And obviously in our society today, there's a lot of things going on when it comes to lack of access, disparities, prejudices. Talk about what you're doing to address healthcare disparities.
So one of the things that our CEO was very intent on was, and this isn't new simply because of what we see happening in our country right now. This is something that he's had a passion for quite a while. But we saw a very real need as COVID continued to evolve and you started to see the numbers across the country. You saw that disproportionately people of color were being negatively impacted more so by COVID.
Right.
They were more sick, and frankly, they were dying at a greater rate than non-people of color. And so this goes back to really what we would describe as systemic racism. It goes back to things like not having access to healthcare in communities of color. It comes back to not having providers who are culturally sensitive and have culturally competent abilities in treating people of color or different ethnicities. And so because this has been something that has existed for a very long time, it really has just reared its head in a really ugly way over the last, 8 to 9 months with COVID, where you really see the huge gap in access to health care, timeliness in how people are treated, how aggressively people are treated. There's even differences in how and what medications are given to people based on where they live and what they look like. And so we formed nationally a healthcare disparities task force. It is comprised of experts from around the country. It has healthcare executives from very large hospital systems. There are executives who are over large healthcare, I would say, organizations like the National Medical Association. We have experts who work in the community health and federally qualified health center space. It's a variety of experts who we pull together, who are now working with our internal team. And so we've got representation from across the country from Centene employees like myself. And what we're doing is we're looking at data that we've been able to collect on our own membership. We're also using data that's been collected nationally because a couple of months ago, the Centers for Medicare and Medicaid came out with data that was very alarming, talking about where they saw the huge disparity in how the outcomes for people who were impacted by COVID. And so what we've been doing is taking that data and we are formulating strategies around how do we as a company, accelerate, if you will, access to care for people. How do we continue to help educate and train providers so that they can be culturally aware, that they have cultural competency in taking care of people. And if you think about here in California, we're a great example where, when I look at my membership, for example, about 70% of our members, English is a second language. That just right there tells you just how diverse of a membership that we serve. And then when you break it down even further, we see that we have a number of our members who come from various racial and ethnic backgrounds. And so it's really important that we are training providers to be aware of those things, that we are ensuring that there are adequate numbers of providers in communities, that we are aligning ourselves with affinity groups that where we can source, not just physicians, but nurses, respiratory therapists, pharmacists, all of the different groups of healthcare providers. And so that's the work that we're focused on, because we believe that we, as I've mentioned to you at the beginning, because we serve a large number of underinsured and people who are not insured, we know that those are the folks who can be caught in the cracks and who will fall in the cracks. And we believe that we have not only a corporate obligation, but a societal and moral obligation to be at the forefront of that. And so I'm really excited about the work that we're doing. It's something that, helps to honestly balance, my day long, meetings of teleconferences and Zoom calls. I really get to do something where I feel that I'm having the opportunity to help make a difference, and hopefully that we can really make a dent in health equity in this country.
Yeah, those are all really good points. I appreciate those specific examples that you're working on, Karen. And it's neat to hear. When I first saw that you're part of the Healthcare Disparities Task Force, I thought it was a Centene thing. Okay. And it might be Centene, but it's also many others, it sounds like, joining together. So I want to applaud you and HealthNet for that, because I do know some health plans, shy away from certain lines of business or certain demographics that might be more challenging and not necessarily the easy population to run a sustainable or profitable business on. So you're really, taking on a big challenge, and I bet you sleep well from what I can tell, because you're doing good work. So
thank you.
Yeah, no problem, Karen. And really just want to thank you for joining the show. I didn't hit record at the beginning. And so you were super gracious, and I was embarrassed. Audience, I told Karen off the air that is 4 years ago, I did the same thing and actually lost footage of the guest. So really appreciate it.
Not a problem.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.